It's always such a privilege to be able to give this talk, ideally face-to-face, but that's not the case this year, unfortunately, with COVID. But at least this gives us one way in which to connect. So, and I think this information is so critically important. So this is a great forum for us to deliver our talks today. So as Lani said, I work as a neuropsychologist and I've worked in the epilepsy space for many, many years. It's an area that I'm really passionate about, and what I'd really like to do today is just, I guess, go through some of the insights that I've gathered over the years, both in terms of my clinical practice, but also touching on some of the research that I've done in this area as well that may be helpful for some of you today. All right, so just in terms of an outline of what I'd like to achieve, so I'm going to spend just a very brief amount of time looking at, I guess, the nature of epilepsy and some of its challenges, and then touch on the role of the neuropsychologist, so what someone like me can offer a child with epilepsy and their family, and then really spend the bulk of my talk looking at the issue of cognitive and behavioural functioning in children with epilepsy, touch a little bit as part of that on the Epilepsy Smart Schools resources that the Epilepsy Foundation have available, and then lastly look at some of the psychosocial and family issues which often don't get a lot of airplay. So I think they're very important issues, and we'll address those as well. Now, as Ingrid did this morning, I'm more than happy to accept questions at the end, and if we can have the video option as well, I'd really encourage you to ask as many questions as you like. The talk itself will take about an hour and 15 minutes or so, and then we'll have plenty of time for questions, so encourage you to do that. All right, so in terms of epilepsy, we know that epilepsy is one of the most common neurological disorders globally. We know that from the World Health Organization. And we also know that the majority of cases of epilepsy are actually diagnosed in childhood. So this is a condition which is primarily one of childhood. So it's very common in children. Now, this is really important because we know that children's brains are still developing. So it means that their epilepsy occurs within a very dynamic context, a context that is very fluid, and it's within that very changeable system that the child develops epilepsy. So very different, for example, from an adult who has a fully formed brain who then develops epilepsy. For children, their brain is still undergoing enormous development. And this has obviously significant implications for that child in terms of the development of their cognitive function, their personality, and their emotional status and longer term outcomes. So it's very important that whenever we think about what might be happening for a child with epilepsy, that we understand that their brain is still undergoing enormous development. Now, there are a number of challenges associated with epilepsy, a number of conundrums which make things a little bit difficult. So we know, as Ingrid has said this morning, that epilepsy can have very many varied causes. And many of those causes, we actually don't know what they might be. And that makes it quite tricky for someone like me who has to then come along and see, you know, what might be the cognitive symptoms associated with that child's epilepsy. So often we just don't know why they've got the epilepsy in the first place, which makes it tricky. We also know clinically that children with exactly the same epilepsy diagnosis, so for example, childhood absence epilepsy, can present vastly differently in the clinical setting. And that relates to a whole number of factors, which we'll go into. So for example, depending on how well controlled the child's seizures are or what various medications they may be on, will impact how the child presents, even though they have the same epilepsy diagnosis. We also know that the clinical course of epilepsy is variable. So some children, as Ingrid suggested, have a spontaneous remission of their disorder, so they just grow out of their seizures, and yet others develop what we call medically refractory seizures. So no matter what medication we give these children, they continue to have seizures. And you know, why some children grow out of them and some don't, we don't fully understand at this time. So as I alluded to, there's a complex interplay of factors that are very important. And these are factors that will vary from child to child. And so when a child comes to see someone like me, it is this very complex interplay of factors that are forefront in my mind for me to be able to understand what might be happening for a particular child. So we have the seizure or epilepsy-related variables, which Ingrid has gone through at great length today, which has been fantastic. We've got the treatment-related variables, and then we have a whole myriad of what we call non-seizure-related variables, which are very important as well. So I'll just walk you through these factors in turn. So we'll start with the seizure-related variables. So as Ingrid has described today, there are some children who have underlying brain pathology. So if we put them through an MRI scan, we see that there's an abnormality, whether it might be a lesion, a malformation of some description, which is the cause of their epilepsy. And that's really important for someone like me to know. Where is that lesion? Whereabouts in the brain? Is it in an area that's critical for cognitive function? That's all very important for me to understand and know about. Where's the child's seizures in the brain? So are they right-sided? Are they left-sided? Whereabouts in the right? Whereabouts in the left? Do they incorporate the entire brain? Where are they coming from? And that has huge implications for how the child presents on testing for me. What type of seizures, and do they have an epilepsy syndrome? Again, Ingrid's gone through all of this in a lot of detail today. So for example, if the child has something like Dravet syndrome, I would expect to see a certain profile from a neuropsychological point of view, given that diagnosis. How old was the child when the seizures commenced? So am I seeing a child who has had seizures since birth? Or, is the child 15 and has suddenly developed epilepsy? So how old was the child at seizure onset? How frequent are the seizures? So am I, looking at a child who has 100 seizures a day, or is this a child who has one seizure per year? A very different clinical situation. And how severe are those seizures? So, are they seizures that hardly anyone, unless you're a trained eye, wouldn't actually see them? Or are they so severe that they're an ambulance trip each time they happen? So just how severe the seizures are and how that might impact how the child presents. And importantly, the duration of illness. So how long has the child had their epilepsy? So, am I working with a child who is newly diagnosed and has, 2 months worth of having had seizures? Or is this a child who's now 15 and has had seizures since birth? A very different clinical situation and critically important for me to know about. So they're the kind of seizure or epilepsy-related variables. And then, of course, there are treatment-related variables as well. So the mainstay treatment for children with epilepsy is medication, as Ingrid has described. And unfortunately, some of these medications have their own side effects. And what we find is that they are typically dose-dependent. So the higher the dose, the more likely we are to get some side effects. And they also tend to be greater when the child is treated with more than one medication. So what we call polytherapy, we know that the chance of having side effects increases when you've got more medication on board. I also tend to work with children who go to have surgery for their epilepsy, and so often it's very important for us to check out whether that surgery may have impacted the child in terms of their cognitive function and their learning. So whether they've had surgery is obviously very important. And then there's a whole lot of non-seizure related variables which are critically important, and again are going through my head every time I see a child in my office. So there's the role of other medical or psychiatric conditions. So this is what Ingrid referred to as comorbidities or coexisting conditions. So things like cerebral palsy, depression, ADHD, autism. It's very common for children who come to see me for them to have a whole heap of other issues other than just epilepsy. And so what's the role of these other conditions in terms of how that child's presenting? Really important for me to know exactly what the child has received in terms of intervention, and has that been appropriate intervention? What's it been like? And as part of that, really important for me to understand the educational support that the child may have received prior to seeing me. So, lots of parents will describe, grade one's teacher was not so good, so that was a write-off of a year, or, whatever it might be. And that's really important information for me to know in terms of understanding what might be at play for any given child. There may be some behavioural factors. So some children we see are very oppositional. They may be hyperactive. What impact is that having on how the child presents? A lot of children that I see have fear of failure, so they prefer not to really try because they're scared. And that's obviously an important thing for me to know about and to see as well. What's the family environment like? So, is this a child who lives in an environment which is really chaotic or stressed, poorly organised, or is this a very calm, in control kind of family, and how does that impact how the child presents? What's the parenting style? So am I seeing very flexible parents who are coping relatively well, or, is it a very anxious kind of parenting style where, and that's feeding into how the child presents as well. So what's happening at the home level, and how burdened, I guess, psychosocially is the child by their epilepsy? So is this, a really big secret that no one's allowed to know about? Or, are they pretty at home with the whole fact that they have epilepsy? So what impact from a psychosocial point of view is the epilepsy having on the child, and how might that be then impacting their mood as well? So I guess, given these challenges, given all of these factors that are relevant, because of all of this, there's no real kind of classic or typical neuropsychological picture associated with epilepsy. And that's particularly the case in children, just because their brain is developing. And so it's a very variable picture depending on the myriad of factors at play. What we do know is the single most important factor influencing academic performance, behaviour and social outcomes in individuals with epilepsy is the degree of cognitive impairment. So cognition in epilepsy is really important, and that's why I work very closely with Ingrid, but also, you will often get one or more neuropsychologists attached to the comprehensive epilepsy programs at all the major hospitals, because cognition in this space is very, very important. So I guess that brings me to the role of the neuropsychologist. So what is it that someone like me can offer a child who has epilepsy and for their family? So what do we do? So basically neuropsychologists are psychologists, and we've done specialist training in the brain. And so what we do is we take and we understand what's happening in the brain, in this case epilepsy. And our brief really is to check out what that epilepsy, or whatever is happening in the brain, in this case epilepsy, what impact is the epilepsy having on a child's cognition or their thinking skills, their behaviour, their mood and emotions, and what's the relationship between all of those things. And so really getting a very comprehensive look at how the epilepsy might be impacting the child. Now, how do we do this? So basically we measure whether the child has any cognitive issues, and we do that by comparing them to their same aged peers. So, if I have a 9-year-old girl in front of me, is that 9-year-old girl performing as we would expect, in comparison to her same aged peers. So we plot the child's cognitive development, we identify if there's any deviations from that expected pattern. So, is the child performing better than we expect, exactly where we expect them to be, or a bit below, and then based on that profile, formulate a diagnosis and then a bit of a treatment plan moving forward. Now, how do we do this? We use lots and lots of tests. Neuropsych test assessments take a very long time. I will often see children over multiple sessions, and it's really to get a very thorough assessment of how the child is presenting. Now, we use lots of tests, so things like IQ tests, which are very important in children, things like attention, their processing speed, their executive or what we call higher level skills, language function, what's their learning and memory, the academic skills, visuospatial processing, behaviour. This isn't an exhaustive list or anything like that, but gives you a flavour of some of the things that we look at in these children. So in terms of what we can offer, a big component of what we do is diagnostic in nature. So Ingrid, for example, will send me a child who may have an epilepsy syndrome, whether it's, Lennox-Gastaut or, Dravet syndrome or whatever it might be. And she might say, does the neuropsychology fit with this diagnosis that we think the child may have? So very much an assessment, diagnostic kind of service. Lots of information about the child's strengths and weaknesses. So, what can the child do really, really well? And can we harness some of those strengths? And where is the child presenting with some difficulties, and how might we be able to compensate for some of those? A lot of what I do is about seeing children over time. So I will see children, for example, if they have surgery, I might see them both before and after surgery to see the impact of that surgery on their cognitive function. So, for example, if a child has temporal lobe epilepsy surgery, it's really important for me to check out their language and their memory function before the surgery, and then catch up with them post-surgery to see if there's been any change following the operation. Seeing children to document the response to medication. So often for our more severe cases, Ingrid may, for example, trial a medication, whether that's a steroid treatment, for example, and she may ask me to see the child before that medication is commenced to get a bit of a baseline, and then pop the child on the medication, and then follow up that child to see if there's been any impact at a cognitive and learning point of view. And then, of course, it's really important for us to work out whether some children may be declining or what we call regressing, which is what Ingrid spoke about earlier. Has the child lost skills over time? And being able to document that objectively is often very helpful. And equally, a lot of children we see improve over time, and documenting that improvement using these objective tests is often very helpful as well. I spend a lot of time making very specific recommendations. So whether that's talking about strategies to optimise the child's learning in the classroom and at school. So what are some specific things that we might be able to do to help a given child if they've got some issues. Also recommending any support services that may be helpful. So, it may be that the child has a specific impairment with maths and that they may benefit from some extra tutoring support, and making recommendations to that effect. Things like speech pathology, occupational therapy, whatever, any allied health interventions, any psychological therapy. And for kids that we're concerned about from a mood and psychiatric point of view, linking them up to psychiatry as well, and psychiatrists in the community. I often get very common questions asked, and one of them is about the best educational setting for a child. So I often get asked the question, should my child really be in a mainstream school, or are they best suited to a specialist school, for example? Or, does my child need a specialist school, or do they need a special development school? So they're common questions that I can speak to and help in terms of making that decision for parents as well. For all children, mostly, or about 95% of children, I will chat with someone at the school. So whether that's the current classroom teacher or the principal, or the wellbeing teacher at the school, whoever, it's really important for me to know what the concerns are at the school level, but also to get a real sense of what might be happening for a child at school and in the classroom. I think it's very, very important. It's all good and well for me to see a child, in my quiet one-on-one kind of office situation, but quite a different situation to then put that child in a classroom setting And it's really important for me to get that information from the school, and I do that as part of my assessment. And then, of course, a lot of what I do is about trying to get extra funding support for children. You know, it's often a battle to try and get extra funding for children who have epilepsy. And so I'm forever writing letters and reports and, you know, whatever we can do to try and get as much support as we can for children, just so that they can be the best that they can be at school, and to maximise their learning. All right, so I guess we'll just shift gears a little bit now and focus very much on, you know, how children present from a cognitive and learning point of view. So the number one question, obviously, working in this area that I get from parents is, you know, what impact are the seizures having on my child's learning? And so this is what we do. This is our bread and butter, to see, you know, what impact the seizures may be, how they may be impacting for a child. So look, neuropsychological deficits can range from, you know, very specific impairments in one cognitive domain. So for example, you know, a child may be completely normal, but have a specific issue, for example, with memory function, or you know, attentional function, and might otherwise be completely normal, right through to those who present with very severe generalised and in some cases quite profound intellectual disability. So there's a very wide spectrum of cognitive profiles, and that's primarily related to, you know, that very complex interplay of factors. So depending on what specific mix of factors, you know, your child presents with, they will present very differently to someone like me. And so critically important as part of my assessment process that I put parents and children through a very detailed interview to see what that mix of factors is and what we might expect from a neuropsychology point of view. Now, we know that cognition can be affected for a whole heap of reasons. So we know, obviously, during a seizure, the child is often offline, particularly if they're unresponsive, and obviously, you know, their cognition is not where it should be. And similarly, during the recovery phase after a seizure, so in that post-ictal phase, often children are quite confused and are not able to think clearly. We also have children who show what we call subclinical activity. So although they don't manifest as having a seizure, you know, if we hook them up to an EEG, they would be firing constantly. So there's that subclinical activity, which can obviously impact at a cognitive level. And then, of course, there are some children who have underlying cognitive problems quite apart from the epilepsy. So there are children, for example, who have intellectual disabilities even before epilepsy is ever diagnosed. And so, you know, obviously that impacts their learning. And then there are a whole heap of the other factors. So, you know, mood. So if the child's depressed, obviously that will impact how they're able to think. Behaviour, you know, if they're not able to sit and learn, obviously that will impact their outcomes, and any impact that the medications may be having on the child as well. So cognition can be impacted for a whole heap of reasons, and that's important for us to know about too. So the research in this space is very clear. So children with epilepsy absolutely have a higher incidence of intellectual, academic and behavioural difficulties when we compare them to their same aged peers. And that's a consistent finding, and we've known that for many, many years. And I guess that's why neuropsychology is so important when we work with children who have epilepsy. What we also know from research, and this again is a very consistent finding, is that children with epilepsy are at greater risk of academic and behavioural problems when we compare them to children with other chronic illnesses. So when we, for example, compare children with epilepsy to children who have asthma or who have diabetes, children with epilepsy always have many more difficulties than those other children. So it's not simply a matter of a chronic illness. I think in this case, in the case of epilepsy, I think because it's a neurological disorder, it involves the brain, and that means that these children tend to be much more affected from an academic and behavioural point of view. Now, having said all of that, I think it's really important, and it's critical that I stress that many children with epilepsy are actually, very normal, in inverted commas, whatever normal is. And so, a lot of this stuff might not actually pertain to your child. Again, it just depends on what that mix of factors is. So there are a lot of children, and, I do see some of them where, their profiles are completely normal, and that in itself can be reassuring for some parents, and nice to document. So not all children with epilepsy will have cognitive and behavioural issues, but there's certainly an increased incidence when you look at the literature. So you may be thinking, look, is this relevant for me? And I guess you can ask yourself some questions, and some of these may ring true, some of them might not. And it might give you a sense of whether you should be concerned about your child's thinking. So, for example, does my child have trouble following instructions or remembering information from day to day? Is my child falling behind in class? Can't seem to keep up with their peers? Is my child more forgetful or perhaps disorganised compared to their friends? Do they take a bit longer to do routine tasks? And does my child show different behaviours from other children their age? So, these, if any of this is ringing true for you, that there may be some alarm bells, and it may be that, we might need to think about, how your child is going from a cognitive point of view. So as I said, a lot of children with epilepsy function completely normally and where they should. But I guess in my clinical experience, there are certain, common cognitive issues that I see, although, profiles will be very different. There are certainly some common things that I see in my office, and there are certain domains. So the first is attention and concentration, speed of processing, and those high level, what we call executive functions. And these are commonly seen in children who have epilepsy, and because of these issues, we then also get secondarily some academic problems. So what I'll do is just run through some of these, purely because they're the most common that I see. It doesn't mean that your child will necessarily show all of these, but they're, I guess, the most common that I come across in my clinical practice. So if we start with attentional problems, research says that, attention and concentration issues may be present in as many as 40 to 60% of children with epilepsy. Look, these issues, in my experience, are very common, even at a very subtle level. And really, concentration and attentional issues do impact all forms of thought and learning for children of all ages. So you can imagine, if a child's not able to attend, it's very difficult to learn. If the information hasn't gone in the first place, it's then hard for them to retrieve and move forward with their learning. And what we find is that even very mild problems with attention and concentration can impact the child. Unfortunately, this is often a common side effect of those anti-seizure medications that we give children. And I think that's why we see them so commonly at a neuropsych level. So attention problems are quite common. So how do these issues manifest? Well, usually the children will have difficulty focusing on important information and just being able to maintain their concentration. These are kids who are usually easily distracted. They have trouble ignoring irrelevant stimuli. They may have problems following instructions in the classroom. The child constantly feels lost and perhaps unable to kind of keep track of tasks, feels a bit confused. They may have difficulty recalling already learned information and concepts from day to day. And so the teachers will often say, we teach them, something one day and then the next day it's kind of gone. And so you get that sense that they're having trouble grasping and really holding on to information. Teachers will often describe these kids as quite vague. Sometimes they feel like they're off with the fairies is generally what they describe them as. And because of these issues, you know, these children often show reduced output in terms of their work. And then we also get all of those academic-based difficulties as well. Now, what can we do? So if you think that this might be an issue for your children, I think it's really important to keep instructions very brief and to the point, so only one at a time. So rather than, you know, asking them a whole series of things to do, you know, one thing at a time, asking the child to repeat instructions back to you. Now, kids are really good at just kind of rabbiting what we say to them. So I often encourage parents to get the children to repeat the instructions back, but use their own words when they do that so that we can actually know whether the information's gone in or not. Really important to reduce distractions, particularly when they're trying to do homework. So, you know, turning the TV off, getting rid of devices, working in a very clean desk, away from the hustle and bustle of everyday life, I think is really important. Really just allowing that child to be able to focus and concentrate as best they can. Encouraging these children to check over their work. And, you know, for older children, having a homework plan, setting an alarm clock. So, you know, these aren't children who can sit and do homework for 2 hours. So, you know, saying to them, you know, you need to focus for 20 minutes, put the alarm on. Once the alarm goes off, having a break and then coming back. You know, they're just not able to sustain their attention for that long a period of time. So doing those kind of things to help them from an attention concentration point of view. So what can teachers do? I think, you know, that there are some minor things that can happen in terms of structuring the environment in the classroom that can help children who have attentional issues. So, you know, making sure that the child is seated close to the teacher, and that the teacher can maintain very clear eye contact with the child at key teaching periods, I think is really important. Ensuring that, you know, the teacher does have the child's attention before giving instructions, minimising distractions. You know, very commonsensical things, you know, breaking down long activities into shorter tasks and providing that step-by-step list so that the child knows exactly what's coming next and how they might be able to achieve a completed task. Allowing the student to take short breaks. You know, teachers are very good at knowing when someone's gone offline and is not so sharp. So, you know, whether that's just a kind of get up and have a bit of exercise and then come back, just reset. Scheduling more effortful activities at the beginning of the day, and providing very clear goals, you know, allowing the child to know, you know, this is what we're going to do in this session so that they know where they're headed and they can concentrate on that whatever it is that they're needing to do. Using objects of particular interest to a child, particularly for younger children. So, you know, if the child's into trains or whatever it is, incorporating some of that so that the child is interested and they're more likely to sustain their attention if they're using objects of interest, or using, you know, concrete or real life examples so that things are less abstract and they're able to sustain their concentration a bit more. So the second, I guess, common finding that I see with children who have epilepsy is what we call processing speed. Now, this really refers to how quickly a child can process and absorb new information and then respond to it. And it very much impacts the amount and quality of the information a person can manage at any one time. Now, children, because of these processing speed difficulties, can take longer to develop new skills, and they may struggle to keep up with their classmates because everything is just coming too quickly at them and that they just don't have the ability to process information efficiently enough. Now, how does this manifest? So difficulty completing classwork and homework within the time provided. So, you know, these are children who, you know, peers, for example, may be, you know, able to write a whole page of writing. For those with processing speed issues, you know, they may get a sentence or two out, and, you know, they're just not able to do anything more than that because it's just all too quickly, and they're just a bit slower to process the information. They may struggle to copy large amounts of material from the board, and they may even just at a social level be slower to trouble keeping up You know, if there's class discussions, for example, it'll take them a long time to try and work out what the discussion's about and contribute into those, as well as games. And lots of children describe it as everything being kind of a bit on fast forward. And so that's very important for us to know. So if this is an issue, you know, I think it's really important that we provide information very slowly. And I'm forever saying to parents, you know, repeat, lots and lots of repetition, because it's what these children need. Again, keeping instructions very brief and clear, and really not rushing these children. You know, they just need time to be able to process information. What we often find is that the attentional issues and these processing speed issues tend to go together. And so, you know, a lot of the strategies help both at the same time. For teachers, I think it's really important that they keep instructions very short, making sure that key points are on the board so that, you know, the child can refer to them. And again, repeat. Allowing the child to perhaps have a reduced workload. So, you know, if there's worksheets, they'll get the same worksheets, but just with fewer items so that they feel a sense of completion, but the workload itself is a bit reduced. I'm forever trying to negotiate homework requirements with teachers for children. So, you know, either allowing them extra time to complete their homework, and in some cases, you know, I try to negotiate whether they actually have to do homework at all. You know, for a lot of these children, the process of going to school, you know, itself is very draining. And so the thought of then coming home and then doing homework on top of that is just too much. So that's often a consideration. Providing handouts for these children so that they can refer to what's been canvassed at school, and also for children who have devices in the classroom, allowing them to take a photo of what's on the board, so then again they can process that information in their own time and have it as a reference as well, is often quite helpful. All right. And the last area that I think I'd really like to look at is what we call these executive functions. And really the executive system, I like to see it as very much the CEO of the brain. So, you know, the executive system does that really high level thinking. So it regulates our thinking and our behaviour. It allows us to problem solve and make decisions. It's crucial for managing very complex tasks and ideas. And really, if you have issues with the executive system, it very much can undermine all other aspects of thinking, especially anything that's vaguely complex. And what we know is that these skills undergo major development during adolescence, and in fact, the executive system is not fully mature until adulthood, so early to mid-20s. And often what we see is some of these issues will come up, particularly once the child transitions to secondary school, when these executive issues become relevant, where they have to start doing a lot more of that complex problem solving, making decisions, and so on. So what are these higher level thinking skills? So they're things like being able to plan yourself through a task, being able to organise yourself, self-monitoring. So, you know, you're performing a task and being able to monitor how you're going with that task, being able to switch and shift if it's not working, knowing how to start a task initially, and then also kind of knowing when to stop, being able to persist or sustain yourself through a task, and knowing how to sequence yourself. So, you know, you do this first and then you do this and then this and then this. Some children with executive issues have difficulty at that level as well. So very much higher level thinking skills. So how do these manifest? So, you know, this may ring true for some of you. So these are kids who leave things to the last nanosecond. They often run out of time, or they don't have the available tools that they need to have to do the task, or, you know, they haven't organised themselves. Often these children have, you know, really untidy and disorganised bedrooms and lockers, and they never can quite find what they need. And because of that, they're often very late to get out of the house in the morning. They don't get to school on time. It's all just a little bit dysregulated, really. They may have trouble thinking up different ways to solve problems. And often, because of that issue with sustaining themselves through a task, they'll often give up after their first attempt or their strategy fails. And they may have difficulty getting started. What we often find in kids with epilepsy who have these issues is the getting ready in the morning is a huge issue. And so, getting ready in the morning actually requires a lot of executive processing, and it's often what children have difficulty with. So what can we do? I think it's really important to set up rules and daily routines to provide that structure for the child. And, I'm a big fan of to-do lists, and, having one of these, what to do in the morning in order to get ready before going to school. So, have breakfast, get dressed, brush hair, brush teeth. So rather than them annoying you in the morning, you can just say, well, have you gone to the fridge to see the to-do list and get them to check it out. So it just guides them. It provides them that structure. If they can write it by themselves, then even better, I think. I think for older children, applying those organisational strategies, so whether they're diary, I'm a real fan of to-do lists, sticky notes, whatever works for children, having a very clear homework schedule, very clear goals, priorities. So, knowing that they need to do, a task that's due tomorrow rather than a task that's due in 2 weeks, just getting them to prioritise their schedule, where and when will the work get done. Helping the child to work out how long a task might take, and then working backwards to allocate the appropriate time so that they can achieve and complete that task. Teachers have lots of ways of dealing with children who have some executive issues, but things like, using simple colour-coded folders and timetables, one colour for each subject. So maths is red and English is green, or whatever it is, whatever helps to provide, again, that structure for the child. Any planning sheets so that the child can work out their approach to tasks, and encouraging them, obviously, if they need to do lengthy pieces of work, how to draft and things like that. So, really breaking down a complex task into kind of constituent parts and helping them through that process. Okay, and then lastly, any one of those issues, so, attention, processing speed, executive function, any, problems in any of those areas really can have a flow-on effect in terms of academic performance. And what we find is that even very mild learning issues can impact how a child performs at school. And there may be gaps that develop in the child's knowledge as a result. And then with those gaps, they have difficulty acquiring things like reading, maths, and writing as well, which I haven't got there. So, there are common academic issues in children with epilepsy. So what can we do if we have identified some academic problems? I think it's really important that if there are concerns and there are issues from an academic point of view, that the child has an individual learning plan. And this is a document that really lays out the child's strengths and weaknesses, and has very targeted goals. It's a really good way of keeping track of how a child's going over time. So it details some of the issues, what we're going to do to try and help that child in that area, and then the plan is regularly reviewed with the teacher and the parent. And I think that that's critical. And if there are any issues from a learning point of view, the child does need an individual learning plan. I think it's really important when I speak to teachers, I'm always emphasising very much an explicit approach to teaching. So using guided practice and lots of scaffolding. So, not presenting information to a child and then just expecting them to do it. It's like showing them, then getting them to do it for you, and then you guiding them, and then they're able to do it independently with some feedback as well as they keep going. So it's a very explicit approach to teaching. Modifying classroom tasks. So I'm always talking about how can we reduce a workload for a particular child. Perhaps they need more time to complete work. Do they need an integration aid? And even if they don't qualify for an integration aid, could that child be placed in a class where there may be other funded children who do have integration aids? And the child with epilepsy could share that integration aid with those other children. So just, basic modifications within the classroom, again, to support that child as much as possible. For older children who need to do exams or tests, arguing the case for special consideration, particularly at the pointy end of secondary school, asking for extra time, extra reading time, extra writing time. Are they able to present orally rather than do a written exam? Do they need a scribe? If written expression is a problem, can they use a computer? That kind of stuff. And as neuropsychologists, we're able to argue the case for children in that regard. And do I think, the child needs some specific tutoring support, and what might be the nature of that tutoring support, or any other remedial programs that we think might be useful for the particular academic difficulties the child may be displaying. All right. So I guess they're the common cognitive presentations that I generally see with children who have epilepsy. Not all children, but they're the common kind of presentations. The second really common question that I get as a neuropsychologist from parents is, what will happen to my child's learning if his or her epilepsy continues? So in other words, what are the longer term prospects for my child? Now, clearly we don't know, we don't know what will happen in the future for children. And again, when I'm presenting in this area, I think it's really important to bear in mind that, this might not apply to all children. And the scenario that I present here is a common scenario, but it may or may not apply to your specific child. So just bear that in mind. So when we're talking about cognition over time, we do see children who have a loss of cognitive skill, and as Ingrid suggested, these tend to be children who have very severe epilepsy, and this is what's called regression. Now, it's relatively rare, and Ingrid and myself tend to see the more kind of severe end of the spectrum, but certainly not all children will regress. So these are children, for example, who may have learnt the alphabet, and in the context of very nasty epilepsy and very nasty seizures, they lose the ability to recite the alphabet. So that would be an example of a regression, cognitive regression. Now, more commonly, what we see in children is what we call slowed rate of normal cognitive progress. So the child may have periods where they stay the same or they plateau a little bit, or more commonly, children will acquire skills, but just more slowly compared to their peers. And I'll just show you a graphic so that we can see that. Hopefully you can see this slide. So this is a very crude way of describing it, but it gives you a sense of kind of the common scenario that I see play out in my office. So we have normally developing children, and then here children with epilepsy in orange. And if we just look at their basic academic performance, and this is year level at school, and generally what I see at a clinical level is that early on at early primary school, or even before early primary school, the gap between normally developing children and children with epilepsy is not that great, really. They're not too dissimilar. But then what happens is over time, you can see that the children with epilepsy are certainly progressing. So they're certainly headed in the right direction. But what we find commonly, and this is not all children, but generally a common finding is that a gap develops between normally developing children and children with epilepsy. So generally, when we get to around about year 3, end of year 2 into year 3, the expectations at school increase. And it's at that point really when we see a gap that starts to develop. Now, ideally, what I would like to do is see children where that gap is very small compared to when, you know, the child's in secondary school and that gap is so big. Now, we can still try and put things in place when it's bigger, but, you know, my preferences would be to get in really early and try and help children if there is a gap, so that they can be the best that they can be and approach this line a bit easier. Now, again, this is not all children, but this is a common scenario that plays out in a lot of children that I see. So how does this manifest? So children tend to be slower to learn new skills, and sometimes children remain stuck at a lower level compared to their friends, and often children themselves will appreciate that they're stuck at a lower level. And as I said, you know, these difficulties tend to become more obvious with increase in school demands, and because of the cognitive issues, that gap develops for some of these children. So how does this manifest at school? We often see increase in academic problems. So where, you know, same age peers may be progressing quite appropriately in terms of their reading level, for example, children who have epilepsy may have more difficulty getting to those increased levels of reading, for example. We may have lots of frustration in the classroom. The child then dislikes going to school, and in some cases they may completely avoid school because it's all just too much, and then we get the development of those behavioural problems. So again, not all children, but this is a common kind of scenario that we see. At home, you may notice that your child is having difficulty keeping pace with his peers, and you might also see some of that behavioural stuff at home as well. So look, a lot of parents early on are told to just wait, and you know, there's a suggestion that the child will catch up. And look, you know, that is the case, that developmentally some children do catch up, but I'm very much a fan of early intervention. So early identification and early intervention. So the earlier you get in, I think the better in terms of outcomes for these children. And really the key to success, I think, is early identification and early intervention. So the earlier we can get in and bridge that gap as much as possible, I think that's key for these children. Now, what I want to do now in the vein of trying to kind of promote early intervention and early identification is just kind of pivot ever so briefly to the Epilepsy Smart Schools program. And this is really, some of you may be aware of it, but it's a program developed by the Epilepsy Foundation, which is very much aimed at supporting students, and teachers and schools really about epilepsy. And it involves a set of tools and resources that schools across Australia, so it's been rolled out across the country, and allowing them to become what we call epilepsy smart. And so, you know, it's all good and well for someone like me to say, you know, early identification and early intervention, but often teachers don't feel well equipped to do that and know where to start. And so this program really is there to support primary, secondary and special school students living with epilepsy, and how best the school can accommodate these children. So I'd very much encourage you all to visit the Epilepsy Smart Schools website. There are some very good resources. And, you know, these are just some examples. So, you know, I mentioned the individual learning plan before. There's a specific fact sheet, if you like, on individual learning plans, which are very useful and may be helpful when trying to establish an individual learning plan for your child at the school level. And there's a really good learning conversations about epilepsy, which is a resource that helps both parents and teachers learn and talk about some learning issues for children with epilepsy. So I really encourage you to look at those. I think Lani, at the end of my talk, will come back and canvass some more about the Epilepsy Smart Schools resources. So we'll get to that in a little bit. All right. We might just keep going. I'm just going to have a look at the time. Yeah. So look, the last section of what I'd like to present today is looking at some of the psychosocial issues associated with epilepsy in children. Now, as I mentioned earlier, this area really doesn't get a lot of airplay, and I think you know, it's so critically important for us to appreciate some of these psychosocial issues when we working with children who have epilepsy, and for us to really appreciate what it is to have epilepsy and what impact it has on the child, but also the family system. Now, parents are forever telling me that there is so much more to a child's epilepsy than just their seizures. So parents will, you know, in good faith, go off and see their neurologist or their paediatrician, and they do a fantastic job, you know, but often the focus is on, you know, what seizures is the child having, what medication are they on, are there any side effects, and then it just kind of stops there, unless you've got a particularly good neurologist like Ingrid. But you know, there's so much more, as you all know, to epilepsy than just seizures and medication, and it's this stuff that no one ever speaks about. There's not a lot of support out there for this kind of stuff, but it's so critically important. And I think in this forum in particular, it's something that I really wanted to canvass. This is the area that I studied as part of my PhD, and I'll draw on some of that as we go through this now. So look, we know that epilepsy can impact a child's quality of life for a whole number and host of reasons. So in terms of physical health, we know children with epilepsy need to take medication. So there's just the demand of medical treatment. So every time they have their medicine, you know, whether it's once or twice or 3 times a day, that is a reminder to them that they've got this thing called epilepsy, and that, you know, obviously impacts their quality of life. For some children, the seizures themselves are very fear-provoking and very, very disruptive, and again, a continual reminder that they've got this thing called epilepsy. This was a quote just from a parent that I studied, which gives you a sense of kind of some of the physical things that might impact quality of life. She is zonked out from the seizures plus medication. It takes her a day to recover from each seizure. So just from a purely physical point of view, there's issues with respect to quality of life. Then, of course, there's a whole heap of emotional adjustment that needs to happen because of epilepsy. Now, we know epilepsy by its very nature is unpredictable. That's just what happens in epilepsy. And for some, seizures can be really quite embarrassing. So, you know, some children make weird noises, for example. Some children lose bladder control. You know, they're very disruptive, and you know, for children who just want to blend into the background and just be like everyone else, seizures really do set them apart. And so this came from a little girl. I worry when it's going to happen next. It's always a concern. It's embarrassing and it's tiring, and yeah, it's bad. So emotionally, it's difficult to cope with the seizures themselves. We know very clearly that there is a high risk of behavioural problems, depression and anxiety amongst children with epilepsy. And even if, children are not clinically depressed or clinically anxious, we often hear about, moodiness, or, the fact that these children often get cranky, they're frustrated by, this stupid thing called epilepsy that they need to deal with. By its very nature, again, epilepsy means that the children are often, restricted. So, for example, as Ingrid said this morning, needing to swim with supervision, some of these children need extra assistance. So the neuropsychologist may say, the child needs an integration aid, but the child probably doesn't want an integration aid, and adjust into that emotionally. What impact does that have on how the child, processes it from an emotional point of view, is really important. Then, of course, the social setting is critically important for children, and we know that epilepsy does impact peer relationships. Children with epilepsy tend to have fewer friends. So this is from a parent. Once she started having seizures in front of her peers, no one wants anything to do with her. She's never invited anywhere. And this from a child, it is harder to make friends because people view me as being a real weirdo. So, that impact at a social level is often critically important. And for some children, unfortunately, they are labelled, teased and or bullied because of their epilepsy. So this was a very sad quote from a child that I studied. They treat me like I'm a tiger. People are scared of me. If I try to do things like them, they say, no, I'm too dumb, and they exclude me. So unfortunately for some children, bullying and teasing is quite a significant issue. For some children, this all becomes too much from a social point of view, and there's a real sense that others don't really understand the epilepsy. And for some children, as a result, they withdraw socially because it's just easier for them to kind of retreat rather than put themselves out there and be subjected to teasing and bullying and so forth. And so this came from a child. They freak when I have an epilepsy fit, so I've stopped telling people and prefer to stay at home. So you can appreciate that it's much easier for her to withdraw and not be subjected to that kind of social disability. And then, of course, the restrictions associated with epilepsy also have social implications. So, for children who, if they overheat in the context of sport, if that is a trigger for their epilepsy, then they may not be able to participate in sports. For a lot of children, sleepovers are quite anxiety-provoking, and so that impacts them as well, and obviously impacts friendships at that level. So this came from a child. I'm not as free to do as many things as I want to do. I always have to be with my parents, like I can't walk by myself, like go to school by myself or catch public transport. So that real sense that that level of independence and how that impacts socially is very critical. And then, of course, all we have to do is add a few adolescent hormones, and you can appreciate that, some of these issues can become, quite big for children. And there's often a need to get some supports in place to help children and adolescents. And then, of course, from a quality of life point of view, there's the educational challenges. So a child who has epilepsy needs to go to school, and then, of course, the school needs to respond to the child who has epilepsy. Now, look, my experience is that schools tend to respond very appropriately with children who have epilepsy. There are some schools that overreact, and I think they mean well, but they have their own anxieties. And I've had a few schools that have actively segregated children with epilepsy, which has just been really difficult. So, what's the school's response to your child with epilepsy? And then, of course, epilepsy impacts school attendance. So if a child, for example, has a seizure in the morning, then getting to school is difficult, potentially, or they may get to school and then have a seizure at school and then need to go home, or they may need to go and have an MRI or an EEG or come and see the neuropsychologist, and that obviously, you know, having all those appointments impacts their school attendance, and that has a huge effect on these children as well. This came from a child. I have gone periods without even being able to go to school. I've been in and out of hospital months at a time. So that's a kid with quite significant epilepsy. And then, of course, there's just the effects of those academic and neuropsychological challenges and the frustration that these children experience as a result of those academic and neuropsychological difficulties. Now, interestingly, what we find is that these psychosocial problems associated with epilepsy are often more disabling than the seizures themselves. And this is really fascinating, because often, you know, I will see children who have very, you know, what we would consider very mild epilepsy, but many of those children are so disabled from a psychosocial point of view, and their whole existence, you know, is just dominated by the effects of that well-controlled mild epilepsy. So, you know, the child's perception and how they cope and their general quality of life is so critically important. And so important for everyone to be aware of. And again, you know, there's that sense that, you know, you go off to the neurologist and there's lots of, you know, talk about seizures and medications, but it's these kind of psychosocial problems that really do need their own attention. And this is a space that really does need a lot more clinical clinicians working in that area. Now, if there's one thing that children say to me all the time, and this is a theme that was very clear that came out of my PhD, is that children just want to be normal. So this sense, you know, all children, particularly, you know, by primary school, mid to late primary school, it's all about fitting in. And, you know, that's for children who don't have epilepsy. And, you know, if you then add epilepsy into the mix, you know, this need for normality, the need to just blend in the background is so critically important for these children. And I think if there's one thing you take away from my talk today, it's wherever possible, and, you know, sometimes it's not possible, but wherever possible, if we can promote this sense of normality for children who have epilepsy, I think that's, you know, that will assist their psychosocial function, you know, incredibly. And so, you know, just bearing in mind, wherever possible, fostering a sense of normality if we can. All right, and so the last section now that I would like to discuss is more of the family-based issues. So again, you know, these are issues that do not get a lot of airplay, but again, I think are just so critically important for us as clinicians who are working in this area to be mindful of, and you know, to be able to support you guys who have children with epilepsy. Now, you know, as a family, we need to respond to epilepsy. You know, it's an event that's not invited. No one wants epilepsy in their family. But as a family, we need to respond, and we need to react to the fact that the child has epilepsy as a family unit. For many families that we see, the process of actually getting an epilepsy diagnosis in the first place can sometimes be quite complicated and torturous. So, you know, you may have had to go to multiple doctors before the epilepsy diagnosis was made, and that is often quite traumatic for some families. Some families have lots of family support, which is fantastic. Others don't. And, you know, what's the life cycle of the family? You know, what else is going on in the family? You know, is everything else kind of in order, or are there other kind of issues within the family? And how is that all incorporated alongside the epilepsy? And then, of course, you know, when it comes to treatment, you know, the challenge of finding the right doctor, you know, is so difficult. you know, it's all good and well to want Ingrid to see your children, but she's, you know, incredibly busy and has a huge wait list. So, you know, knowing that you've got that right doctor is difficult. And then when you do get the right doctor, that kind of trial and error to find the proper treatment, you know, the meds and so forth, and that itself is an evolving process, because, you know, often children will show honeymoon periods, so they'll be settled for a month or two on a new med, and then they'll have breakthrough seizures. And so it's just this constantly evolving process, and that balance between, you know, reducing the seizure activity, but then also being mindful of the side effects that come with that. And, you know, as a family, how do you navigate all of, you know, these issues? They're big issues. As parents, you know, we've got objective caring tasks that we need to do for any children, you know, quite apart from epilepsy. But then, you know, epilepsy certainly does have a secondary effect on caregiving, on every aspect of life. So whether it's, you know, your own work situation, your own social interactions, your, God forbid, leisure activities, you know, epilepsy, you know, can impact at so many levels for parents. This came from a parent. So this is a mum who said, we don't go out as much as a family, and if we do, we often have to come back because there has been a seizure. We miss the innocence of family life, just going out when you want. Grief has taken over that. We miss out on that. And I think that the mention of grief in this context is often critical, and just shows you, I guess, the quality of you know, what impact epilepsy can have at a family and at a parental level. And of course, as parents, we need to incorporate the various demands associated with epilepsy into our established routines. So, you know, if the child goes to school and then has a seizure, then we're required to leave work and you know, go pick up our child. And so, you know, we need to incorporate everything that comes with epilepsy into our lives. You know, we need to bring our children to the appointments. We need to go see the neuropsychologist or whatever it is. You know, it's just an added layer of complication for families. And then, of course, as parents, we need to respond to the epilepsy, and a really common feature of that response is worry and anxiety, and this was a very clear theme that came through my research. So this from a parent, you know, I'm a nervous wreck, all I worry about is him and what he's doing, and if he's all right, I'm wound up like a real tight ball. And what we find is that epilepsy for children can cause stress for parents, and that's a very common thing. And for some parents, it causes distress. And some parents that we see develop what we would call clinical depression or clinical anxiety, and it's really important, if that's the case, that you seek treatment for that, and therapy for that. There's a lot of reasons why epilepsy is anxiety provoking for parents, and why there is this constant sense of worry. You know, by their very nature, seizures are uncertain. We also don't know about the longer term prognosis for children. You know, are they going to have another seizure? Are they going to be well controlled? You know, what does it mean for them in the longer term? And as I mentioned, you know, just that grief, you know, what could my child have been had it not been for this thing called epilepsy, and really grieving that the loss of that child that could have been, and all of the emotions that are attached to that. Parents that I speak to often speak of this roller coaster of emotions. So, you know, you feel like you're kind of on top of it, and then, you know, there might be a breakthrough seizure, or something might happen at the school or whatever, and then there's this constant kind of roller coaster of emotions as you navigate through this space. There are also, you know, significant disruptions to the family roles and responsibilities. Often we find that mums need to, you know, take the lead, and they often take the lead in terms of, you know, appointments and coordinating the epilepsy and everything that comes with it, the supervision that is required. So this from a parent, I can't allow her to do basically anything without someone supervising her all the time. So that real need for supervision. and how does that impact, you know, the roles within the family and who does what. So if, you know, mum's busy supervising, then, you know, what's happening, you know, with the other things that need to happen and so on. And how might that impact relationships, including siblings? Often siblings of children with epilepsy are in the background, and you know, they often call out for their own attention in various ways. What are the changes to the marital relationship when there is a child with epilepsy within the family as well? This from a parent speaking to the sibling issues. They resent that she gets more attention than them. They actually said to me that you treat her like she's cotton wool and you let her get away with a lot more than we do. So that real sense that, you know, you're treating the kid with epilepsy very differently to us. And so what impact does that have on siblings as well? And then, of course, you know, the challenge of parenting a child with epilepsy. You know, parenting is a difficult gig, you know, at the best of times, let alone adding epilepsy into that mix as well. So, you know, how do you parent a child with epilepsy? You know, how much freedom and how much leeway and independence do you give a child who has a seizure disorder? And it's a really difficult you know, really difficult decisions that you need to make as parents, and getting that balance right, you know, letting the child have a normal childhood, because that's what the neuropsychologist has told me to do, but at the same time having the fear of letting them go, because, you know, what if they have a seizure? What if I'm not there? What if, you know, and so on. This balance is difficult for any parent, but I think this is magnified when we add epilepsy into the mix for parents. There's also, you know, the social implications for you guys as parents. So parents often speak about just feeling isolated and feeling like other parents, you know, at schools or, you know, at your child's school or whatever, or your friends, you know, their priorities and their experiences are so vastly different from what you're going through. And that sense that, you know, they don't quite appreciate what we're going through. So that sense of isolation that comes with that. Epilepsy, there is no doubt about it, still has stigma associated with it, and that is a significant issue for a lot of parents to deal with. And then, of course, there are some financial issues for some parents, particularly those who can't maintain work because the child's seizures are so significant, and what's the impact of that. And then, of course, you know, the threat of death, you know, particularly for children who have very severe seizures, you know, SUDEP is a very real issue, and is ever present, and certainly adds to the anxiety. So what can we do? I think it's really important to not ignore problems. I think the earlier you act to prevent longer term issues, the better. So if there are any alarm bells going through your head, you know, whether it's from a learning point of view or a psychosocial point of view, you know, what's the child's learning like? What's their cognition? What's their academic performance like? If there's any alarm bells going off, I think, you know, the earlier the better really is the take home message. Talking to your child's teachers regularly is critically important. You know, even if you come across as, you know, being a really difficult parent, and it doesn't matter, you know, you need to maintain that level of communication with them at all times and asking very specific questions. You know, how are they going? And if they're not where they should be, then what are we going to do about it? And being very clear that, you know, we're headed in the direction we need to go with as much support as we can. And advocating for your child at every turn, you know, you're it for them, and really taking on that advocacy role as much as you can is so important. I think it's important to observe your child. You know, are there any red flags going off in your head? Are there any warning signs? Now, again, this is not an extensive list, but, you know, things like, you know, are they crying, or is there reluctance to go to school? Are they moody? Do they have emotional outbursts, particularly after school? You know, a lot of these children try to keep it together at school, and then they get home and they kind of, you know, have meltdowns. You know, are they having difficult behaviour at school? And then they're okay at home, or vice versa. Any difficulties with homework, any reluctance to talk about school, and, you know, are there any negative comments about their teachers? That's, you know, when kids are frustrated, that's how, you know, these things kind of manifest. So any of these kind of warning signs would be good to see. Of course, we need to celebrate little accomplishments. You know, it's not all about academics. It's not all about cognitive function. You know, that's certainly my emphasis. But, you know, there's so much more that we can do to promote a child's self-esteem. You know, it's not all about academics, praising them for their efforts rather than just the successes. And really, if anything, you know, just trying to make home as safe a space as possible for these children. For a lot of kids with epilepsy, you know, school is, you know, they don't feel like they belong. You know, there's the social issues, there's the learning issues. And so if we're able to make home their safe space where they're valued and they feel seen and you know, a sense of belonging at home, I think that's really important. I think it's really important to get help, whether you've got family supports, any supports you can gather from the school, whether that's the wellbeing teacher or any supports that you can get. I encourage you to do that. Friendships of your own, and of course the Epilepsy Foundation have so much support that they offer, and I'd very much encourage you all to tap into that as a resource as well. I think, you know, part of giving this presentation in a face-to-face capacity is we find that parents who attend our talks will often, you know, get talking with each other, and there's often a lot of connections that happen, and that sense that, you know, I'm not the only one dealing with this kind of stuff, I think is really important. And unfortunately, we're not able to do that, you know, using this virtual kind of medium. But, you know, any opportunity that you can get where you're able to connect with others in a similar situation, so there's that sense that you're not alone, you're not doing it alone, I think is really important. Now, whether that is face-to-face or whether, you know, things like Facebook or whatever it is, social media, you know, whatever it is, I think some of that can be quite helpful. I think finding a strong doctor that you trust is critical, particularly in terms of easing your own level of worry. Not always as easy as you'd expect, but trying to find a doctor that you trust, I think, is important. And of course, you know, a little bit of self-compassion. As parents, I think we don't do a lot of this, but really looking after ourselves. And, you know, even if it's just little things, you know, going for a run or, you know, reading a book or vegging out in front of the TV, whatever it is for you, I think, you know, I'm often saying to families that, you know, we need to put on our own oxygen masks before we can assist our children. And I think, you know, we need to look after ourselves in order to be our best for them. So I would encourage you, if you can, to do that as well. All right, so I was going to pivot to questions, but Lani, did you want to come on now and just canvass some of the epilepsy smart school resources?
Certainly. Thanks, Silvana. That was marvellous. I want to acknowledge that Silvana's already touched on some of the things I'm going to address very, very briefly, but also to acknowledge that she was an integral part in creating some of the fact sheets and brochures that we do have available on the website. Now, James has shared the homepage of the website, the Epilepsy Smart Schools .org.au is the website that we use. And it's important that we note that the program has been developed to support students and teachers in the school setting. And my background prior to joining the Epilepsy Foundation was I was a school nurse for 15 years in a special developmental school. And I can tell you the resources on this page I promoted very, very strongly, and our teachers loved these resources. And I think taking the time as a parent to see what's on this website and raising those issues with the school is really, really important. So every school has a duty of care to provide a safe environment for a student with epilepsy and to accommodate their needs. If you look at the website main page, it has 3 main areas that it's broken down into 3 sections for 3 groups, and that's teacher and staff info, parent info, and then student info. So if you click on each of those, they'll have lots of different specific information for the group that you would need. There are also 3 steps to make the school that your child goes to epilepsy aware, and it starts off with the management plan, and every student at the school that goes to school should have a current epilepsy management plan and possibly an emergency medication plan if that's required. And they should be current and updated every 12 months for the school. And you can click on that particular part of the website to get a copy of the plans to download to take to the school or to take to your neurologist to get them completed for the school at that time. There is also training available. So if you opened up that link, you would see the training options for the school to do their training, whether it be online or whether we come to the school and present a face-to-face program for the school in introduction to epilepsy. During COVID, we've had that opportunity to update the online modules that we teach, and we've now developed a specific one for teachers, which has got lots of resources for them to utilise as well. So it talks about the training and what's available for there. Then the third point is raising awareness, and there's lots of things that talk about what we could do at the school level, and it can be big whole school events like an Epilepsy Purple Day, or it could be a Purple Cupcake Day, but most importantly I think is the grassroots information that's available for teaching staff. There's some crafty classroom activities, how to make a brain hat. Have a look at that, it's really good fun. I suggest everyone downloads that and has a go, and actually looks the brain. It can be coloured in and cut out, and it will show you the different sections of the brain that the different seizure presentations might come from. It also has some classroom activities that are age specific, so it might be for prep to upper primary school, then the middle school years, which is the mid to upper primary, and then upper primary to secondary school years. So the class activities are specifically related to that child's age, and that each classroom teacher could download those and utilise those as well. There's also a multiple supply of different fact sheets, brochures, student individual learning plans, and links to our Epilepsy Foundation YouTube videos, which are really good that the school can also use, but you can also use for your family and friends as well. So that's just a general quick overview of our Epilepsy Smart School program. I invite you to have a bit of a search through that and talk to your school about how they can support you and your child in that school environment with their learning. Thank you.